So I guess we're live. Yep, YouTube says so. Stream is healthy. Yep. Stream settings. I'm supposed to have some kind of plugin, Chrome plugin, that let me yeah. Oh, yeah. I have this neat plugin, Chrome plugin that let me highlight chat messages in real time. Let me see if I can make it work. Test 1 2 test. I click it. It doesn't work, of course. Why should it? Let me just update. Nope, it doesn't work, of course. Just one more time. Okay. Hey Tim, what's up? Just testing stuff before reading some crazy ass oncology exam that just got sent to me again after I tossed the way back to the platform. Just testing a Chrome plugin that was supposed to work but doesn't. Oh, that's nice. Good luck with that. Thermal paste is awesome. This is, I guess this is it. Just let me click it again. Yeah, it works. Ha! Okie dokie. Let's see. I hit clear, it clears. I hit the message, it shows up. Fine. So let's begin. What if I did restore the chat, and it only works if I make the chat pop out. So I'm just going to fix it right there. Yep. Yep. Right there. Always on top. And we are done. Let me just share my screen. Hey Tim, how's the sound? Is it okay? My audio, is it fine to listen when I talk? I didn't put any filters on. I wonder if it's all crackly and noisy. Thank you. It's nice to know. So this is a test stream. I'm going to read some exams and comment on them as much as I can, because I am actually working from home. I'm not just streaming for fun. So if you want to ask anything about the exams, just be my guest. You are very, very welcome. Live chat. This was supposed to work much better than what it is right now. It's kind of stupid. Stupid plugin. Yeah. I'll leave it like that. I'm just not going to be able to fix it on stream anyway. So I have here a 48-year-old female. She says she has some kind of abdominal pain and so painful abdomen. I just can't really deal with this. It should be different, but it isn't. Let me just, yeah, like that. No, that won't work. Oh, gotta work. So, screen share. And I shouldn't do this kind of screen share. I should be doing another kind of screen share. I don't know if it's going to work. This kind of screen share. Let me open up the exam, see if it shows. It does. No sensible content showing up. Fine, I can't really have this here. Man, this chat is terrible. This chat screen is awful. I'm just going to give this up. I still need some kind of chat monitoring to make this work. So I guess this is going to work. So this is a abdominal CT scan, both superior abdomen and pelvis. She has had some kind of surgery for endometriosis and complains of abdominal distension, puking, and pain. Of course, she is 48 years old. I have a pre and a post contrast scan. No, I don't have it. Oh, once again, they sent me the wrong exam. I can't report this because there is no pre-contrast phase. This exam once again is incomplete. I'm just going to write it down. Não tem fase pré-contraste. Yeah, they are that kind of stupid. I was pretty clear. I can't report a abdominal CT scan if you don't send me the entire scan. It makes no freaking sense. Still, they sent me back the same images. Still the same incomplete scan. So let's see what else we have here. We have over 50 emergency CT scans. Let's grab a head CT scan. To start off, this patient also has a chest CT. So chest CT and head CT. I'm downloading, and I should do something about this chat. Maybe I could make it float. I wonder why it's the floaty chat is huge. It's just just a floaty. Yeah, I can't make it go right there, just won't work. Yeah, maybe right there. Yeah, I think right there is okay. So I can skip ahead. Let's open up. Is sensible content showing up on stream? No, it isn't, so I can report it. Let's start off by looking at a terrible CT scan of the head. No contrast enhancement and no clinical history whatsoever. So, so let's go. So there is mild chronic brain disease, some hypoattenuating white matter. Ventricular system is fine. Can't see much, no blood, no major calcifications. Some tubes. Not talking about tubes, this is a head CT scan. Mastoids, temporal bones are fine. Sinus are fine. Orbits are okie dokie. Soft parts are as much as they can be seen normal. So this is just a regular old man's head CT scan, no major disease. Now let's write that down and send it away. Grab me a template right there. Template has been pasted. Mild hypoattenuating white matter, brain white matter, and the ventricular system looks fine. Just copy and paste it. I have phrases all done, all ready for copying and pasting. Yeah, kinda normal for his age. Hey Tim, I'm looking forward to setting up the Discord server for incorporating the chat, the voice chat in OBS, so I can hear you talk as we scroll these images. So maybe in the next few days I'll look into it. I'm just really tired. I had a very bad night of sleep, and I'm not in the mood to fiddle around with OBS today, but I'm looking forward to it. Thank you. I think it will be nice and much less boring for whoever is watching, because it's just me ranting and slowly commenting on stuff. Oh, that's nice. I went to bed, I guess it was almost 1 a.m. and I got up around 6, but I really didn't have a restoring healthy sleep cycle. Just agitated and I don't know. I woke up as much tired as I was when I went to bed, so that kind of sleep. So this one went off. Let me grab the chest. It says chest CT scan here, and from the thumbnails, I'm pretty sure this is a bad one. Oh, 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 no way, the feeding tube is all over the hypopharynx. These guys are nuts. Come on, man. Come on. Check this out, Tim. Check this out. How is this feeding tube? God, these guys are nuts. Thank God there is a tracheal tube right there and a massive, huge, massive tumor taking over the entire left lung. Oh God, this is awful. This is as awful as it gets. Can't be much worse than this. God. Oh man. Oh, how bad is this? As bad as it can ever get. God damn. Let me check bone first. So, is there bone lesions? Are there bone lesions? Are there? No. Just a huge, humongous killer taking over the left lung. Yeah. Let me grab a template. Of course, I have a template for that. Why not? This is everyday oncology CT scans every single day, folks. Nothing new. There is a small pleural effusion on the right, and yeah, probably this is some kind of rapid growing, those anaplastic killers we often see on lung cancer cases. Sometimes lung cancer is extremely rapid and devastating, just like this, and there isn't much bone erosion. You can't really tell, and it kind of limits itself to a portion of the mediastinum, so it's really taking over most of the lung and the airways, but it's kind of enclosed inside the lung area and the pleural structure. So there is clear infiltration of the mediastinum right there. So this is definitely a tumor, a huge, overly necrotic tumor. This is really, really massive and bizarre. So some kind of massive adenocarcinoma of some kind. Maybe one of those rare tumors such as oat cell and small cell carcinomas. Those anaplastic bizarre stuff. I have no clinical history. I just know this patient is oncologic because he comes from a oncology hospital. So yeah, I'm just going to report that the feeding tube is in an anomalous position on the hypopharynx, because this can't just be like that. So I have reported the mass. It's a huge mass. It takes over the entire lung and the mediastinum. And there is a hypertensive effect because the heart is dislocated to the right, so this has a huge mass effect. Also, there is consolidation and atelectasis of about 1/3 of the lower right lobe and the middle lobe, which is also a major concern. Yeah, this patient is on the way to pass. Just I don't know what they could do to improve, because this seems really solid. How can you thoracotomy, a chest surgery to remove the bulk of this tumor would be a major, huge surgery, and it would make no sense, because it might just kill the patient just by going into surgery. I guess they are trying some kind of chemo to make it shrink. I guess I have some previous exams. Yeah, I think so too. I think this would be a bad idea to operate on this patient. So we have all that good stuff about old age patients, because there is atherosclerotic disease. So I'm just going to report the aorta. And can say the heart is normal position, because it isn't. It is dislocated to the right. And I can't say the main bronchus on the left is fine, because it isn't. And there is a mediastinal mass for sure. So this exam is mostly just reporting the mass. It is a hypertensive effect over the remaining lung parenchyma. I'm just going to download some exam that was done 10 days ago to see if anything has changed, if there is anything to report as a comparison to this one. So it's downloading quite fast. See you, Tim. Have a nice one. Watch out for traffic. Drive safe. So, download is done. This is the old exam. This is today. And this is, oh yes, this is 10 days ago. Oh, it got worse. It got really, really worse. Yeah. This could be a mesothelioma. This could be a carcinoma of the pleura, of the pleural surface. This could be just getting bigger and bigger. This could be a pleural tumor. Right here it looks solid to me, but if we compare to there is some lung and some encasing, a solid heterogeneous necrotic encasing of the lung. This is very, very common on cases of malignant mesotheliomas, cancer of the pleural structures. So it got worse. Yeah, it can grow quite fast. It does. I have never seen it grow like that in 10 days. Maybe they started chemo and it got filled with fluid, necrotic fluid, and got this big quite fast. Maybe there is some kind of bleeding component right here, and this is probably due to chemo. And on the last exam, the patient wasn't intubated, had no tube, no tracheal tube, and he clearly got worse, and they had to put him under the tube. Yeah, this looks like a major necrotic area. It is kind of insufflated. I'm just taking wide guesses right here. I could never actually be sure about any of this because I don't have access to anything else but the images, but it seems like it's much necrotic today than it was 10 days ago. The fluid component and some sort of bloody component seems like it got bigger, larger, encasing and collapsing the lung. Hey Hodem, what's up? Welcome. It is a terrible, horrible, terrifying, nice case. Encasing the lung. I'm sorry, I couldn't resist that. I couldn't hold myself not making that stupid joke, I'm sorry. So, let's say it got worse. Yep, and we got it. It's done. Let's move on to the next one. There is a suspected stroke right here, guys. suspected stroke from the emergency. It's a woman, 73 years of age. It says, let's see what it says. It says it's loading, it's downloading. Come on. How's the stream quality doing? I don't know. Am I still streaming? I wonder. Yeah, it says healthy. Yeah, it's for a stroke. It's a stroke patient from the emergency. So it's that nice stuff. So it's here. Is it here? No, it isn't. It's stalled. So let's download once again. Go, go, go. Patient is dying. Come on, download it. Yeah, this sucks. Come on, man. Yeah, sometimes their system is just like that. I hit to download and it goes really, really slow for a few minutes, then it gets back to being as fast as possible. So I have to keep on pushing download and wait for the downloads to actually work. No, not at all. Once again. So this is why it's tough to live stream on this stuff. Just can't download the freaking exams. I'm just going to switch ISPs and I'll be right back. I guess the live stream might have fainted a bit. Yeah, it got back, just a hiccup. Yep. So let's see if I can download the exams. Download has been hit and it's downloading. So I have a couple of internet connection providers here at my home office because every single day I have to switch between the two to be able to download the exams, because there is some kind of bug on the platform. It just blocks me after lots of downloads, and this is for a stroke patient. So let's just check. Yeah, you guys are watching as much as I am. So this is a 73-year-old female patient, and this is supposed to be an acute stroke. 80% of acute strokes are ischemic in nature, and when hyperacute, less than 6 hours of the ictus, the start of the symptoms, we just can't notice anything, no matter how severe the stroke. So this patient has some reduction in brain volume, some dilatation of the ventricular system, nothing major, atherosclerosis, but I can't really tell any acute signs of stroke, no bleeding, no mass effect, no major signs of anything, just old man's brain. So this is old man's brain. There's some sphenoid sinus anomalous content right there, minor, no need to report that. Just let's keep ourselves focused on the brain. So the brain is fine. I'd never waste my time on CT scans for such cases. If I had a MRI scanner at hand, back in the day when I was working inside the hospital, in the tech room, shoulder by shoulder with the guys that actually make the exams, we would always put these patients on the MRI scanner for at least a flare and a diffusion weighted sequence, so we could grab every single case of acute, hyperacute stroke. Good times, not going back, but I still remember such nice times back in the day. So I recommend, I tell people as much as I can, don't do brain CT scans for acute strokes. Do quick emergency protocol MRI scans for such cases. It's way better and makes total sense. This makes no sense unless you have no access to a MRI scanner, of course. If you don't have an MRI scanner, do CT. If you do have an MRI scanner, don't waste your time nor your money on this kind of cases. So this is a chest CT scan. It's a I don't know, male patient, I guess, and it says pneumonia. So this is a pneumonia screening exam, chest CT. Young patient, probably a male. His name is Odd, I can't really tell, and whoever sent this patient in says he is male, so I'll take their word for it. So this is mediastinum, this is lung. Let's roll. Is there any signs of pneumonia? No signs of pneumonia, just a regular CT scan from the emergency. This is nice CT scan to report. There are some tiny bands right there close to the major right fissure. I don't care, I'm not going to report that. This is an emergency CT scan. This patient has gynecomasty. He has breast mammary glands, bilateral glandular breast tissue in his chest, and this is pathological, related to genetics and estrogen exposure. Some mild calcification on the coronaries, and this is it. Esophagus is fine. Always look for esophagus stuff, thickening of the walls and obstruction and liquid fluid, air fluid levels and whatnot. Let me just hit an FPR and look for any kind of bone disorder. The lung recon is much better to look for bone because it's much crisper. Patient has a anterior longitudinal ligament ossification. Nothing major. Sternum is fine, and the spine has just mild signs of degenerative disease. Nothing major. There is no trauma, so I'm going just to scan over the ribs and the collarbones, which are the clavicles. No, so this is a fine and dandy normal exam from the emergency pneumonia. Any sources? You mean books? Books for reading or channels? What do you mean, Holden? I have a few books I recommend for reading. I think you should start off, I don't know how much you're into studying radiology, but I always, if you know the basics, I mean the medical basics, anatomy and all histology and basic technique, I think you should try a... Oh, you're way into radiology already. So, back in my time, I studied the textbooks on general radiology. Then I went to particular textbooks, especially for head and neck and brain, and for abdominal radiology. So, and some I have a bunch of articles about particular subjects. So, for example, if I want to study lumbar spine MRI, I go to the web and look for 20 articles about that from major publishers, and just download them and read them and try to apply all my daily practice. Pretty much that. I still have, I guess, on my Google Drive around 200 articles or so about a bunch of subjects, and there are some review articles about specific stuff, just like for example, cervical cancer, uterine cancer, prostate cancer, the classifications, PI-RADS, BI-RADS, O-RADS, all of those classifications. I go to the original classification, download the material, and work on that and practice. And it's always really, really useful to have someone with more experience to share experiences, to share cases, to ask around. So if you, I just started my Discord server. I'm pretty new at Discord myself. So this is just me, my kid, who helps me out with the tech stuff, and he is only 11, and Tim, who was just here a few moments ago, and you, if you join, and we can chat, we can share stuff and cases over there. It would be nice. It's on the video description right there. Let me just grab it and paste it in chat. It's been a long time since I last streamed anything. I used to stream on my Portuguese channel. I have a channel in Portuguese, and this is a very new channel. I'm just going to paste the Discord right there, grab it and paste it. Oh, it's there it is. Oh, I feel you. Back in my day, in residency, I did not have much formal teachings and classes. I was hired as a resident, and I had to work my ass off and make some kind of way to figure out some kind of way to learn. Of course, I had a lot of cases, tons and tons of exams, and if I make the correct answers, I would be lucky enough to be answered and to be taught. But if I didn't make it, if I didn't work for it, they wouldn't just teach me out of the blue. They were working as much as I was, and I was there to observe and trying to learn. But it's not an easy way to learn radiology, but I think if you have enough experience and you have people to ask and to share and to show you stuff eventually, from time to time, it's there. You can learn radiology like that. You have to go to somewhere to practice and to study and ask for pointers and for directions. And if you make a mistake, people have to be around to correct it so patients won't suffer. And that's pretty much what happened to me, and I could manage to get out of there and work on my own and become a radiologist. So here we are. I guess most places are like that, at least in Brazil, as much as I know. I don't know in the US or wherever you are, but in Brazil, you gotta work it. They just won't give it to you. There is no easy learning. Not like school. School is easy. College is tough. Med school is horrible, and residency is just impossible. But I guess you can handle it. You can make it work. Just keep pushing it. So there is no pneumonia here, just gynecomastia and nothing else, some spondylosis. So let's send it back. Oh, thank you for watching and being around. I really appreciate it. I know this YouTube stuff is kind of tough, you know, starting off a channel from scratch. YouTube is rough. So I have a 24-year-old male patient. This is another CT scan of the chest, and it's for some kind of infectious disease, most probably a pneumonia. Yeah, musculoskeletal, bones and joints. Radiopedia is a nice place to start off or to remember stuff, but be sure to check the references for the articles and read on those. I pretty much do that. For example, if I want to study, as I did a few years back, on MRI for colon cancer staging, and I go to Radiopedia, I read the article and make sense of it. Then I went to the references and I downloaded the references and started reading from the places the guy that wrote that article actually read from and studied, and it makes me more confident. And of course I can grab the details of the stuff that really isn't on such a small article. So it makes much sense to me like that. Oh, thank you. I'm pretty much here for the cases and for the explaining, so be very welcome. These live streams are fun for me to do because it's boring. My days are kind of repetitive and boring. I just do this every day from Sunday to Sunday. So sometimes streaming and chatting makes the day go by easier. And once or twice a week, I try to record those videos and edit them and upload them to YouTube so we can grow our community and make my afternoons and evenings less boring reporting scans. So this is a normal CT scan. I'm pretty sure whatever infectious disease this person has, it isn't in his lungs. So normal CT scan, it really isn't every day I see a normal CT scan. Most CT scans of the chest are quite diseased, are quite screwed up. So this is easy, and it's done right there, done. Yep, baby. So let's grab a abdominal CT scan. So this is the abdomen. I have a previous exam from 1 year ago, and it says nothing. Why the heck did they order this exam? Let's see if I can figure it out by reading a half filled exam order. It says kidney stones. So this is a kidney stone survey or follow-up. This is fun. This is easy, unless it's not. This is a 35-year-old male, so it should be easy. Let me grab its non-enhanced. So fine, non-enhanced CT scan. I have a template for this non-enhanced CT scan of a male, young male, right there. So the template is there. And let's go. I'm rolling down the images, and there is as much stones as there could possibly be. And indeed, this patient has a kidney stone problem. Yeah. Right there, it's all white over the gray kidneys. So his gallbladder is closed up, almost closed up, contracted because he ate just before the exam, and pancreas, spleen, colon. I can see right here the appendix is fine. Appendix is okie dokie. And we have microstones all over both kidneys. I'm not going to waste my time counting those up because it makes no difference. So I'm just going to report there is no hydronephrosis, no dilatation of the urinary tract, but there is as much stones as there possibly can be. Oh, look at that. Look at that. So just follow up the urinary tract from top to bottom. Be sure there isn't a stone somewhere else. No, there isn't. And I'm just going to say the appendix is fine, just to be sure. Since this is a major case of kidney stones, I'm going to download the last exam and do a quick comparison to make it final. See if the patient had a worse issue last year or if he got better. So this is from last year's and it's quite the same. He had some kind of metallic artifact on the colon, I guess, on this case. Yeah, he had swallowed some metallic fragment and look at that. That sucks. So it's the same, nothing major has changed. So nothing major. I'm just going to chat. I'm just going to ask for some MRIs so people can send me over some MRIs because CT scans are boring. And we'll be out of exams very soon. Just going to, yeah. So we have another CT scan of the abdomen. I'm downloading them. 64-year-old male. And for what? It says cancer, rectum cancer. He's under treatment for rectum cancer and complains of bleeding. Can't be good, can it? I guess it can't be good. It's here. Let's see, I have a pre and a post contrast phase. Yeah, they did just a bit of contrast enhancement just to make my life harder, because there is so little contrast enhancement here. They just take a huge patient and infuse just a tiny bit of contrast. There is some calcifications inside the gallbladder. Could be calculi, stones, could be some sort of polyp. There is kidney stones also, and some simple cysts. Old patients have old people's disease, and they have indeed taken off something here. It's not rectal cancer, it's a right-sided colon cancer. This patient had a hemicolectomy, a right hemicolectomy. They took off half his right half of the colon right here. This is the anastomosis right here. Where is the jejunum? Yeah, the jejunum is right there. This is the anastomosis. What is this? No, this is the anastomosis. It is thickened and it has some kind of stranding of the mesenteric fat and a bunch of small nodes. There is some kind of irritation right there on the bowel loop that is connected to the reminiscent of the colon, the left colon. No thrombosis. Yeah. I don't think this is cancer. I don't think the cancer got back. I think this is some kind of inflammatory or infectious disease at the surgical site, because this isn't a recent surgery. This doesn't look like this patient has gone through surgery recently. So, because usually they get a colostomy for a few days, weeks, or months, and then they have the anastomosis done, and even when they don't go like that, they have a primary anastomosis after a hemicolectomy, a half colectomy. They usually have major inflammatory signs in the abdomen. He has diverticulosis, an enlarged prostate, a lot of atherosclerosis, and the jejunum, the ileus is thickened right there on the mesogastrium, at the site of anastomosis, of enterocolon anastomosis. Kidneys are fine, don't look like chronic disease. I have 1, 2 microstones on the left kidney, some thickening of the adrenal glands, which is very common in oncologic patients. No signs of secondary disease on the liver nor the spleen. Let me see, bone. What's up with the bones? Bones are okay. Lymph nodes fine. So nothing really major, just late post-op findings. Yeah, pretty much you have no history. Sometimes you have the inverse, you have a history of some other patient, and you have quite the opposite of of a proper history. And sometimes they send you the left side, and the patient is supposed to have a right side joint scanned, and you gotta work with what you have. It's really like that. So it's radiology is half guesswork, half science, I guess. Training, proper training. So let's say stuff about this. I have a template. I have a template for old man's contrast enhanced CT scan of the abdomen, of course. I'm not that stupid. I'm just going to state the surgery. And I'm going to say there is thickening of the ileus at the site of the anastomosis. I get to check my spelling, because yeah, that's it. So the cysts, it's 58 millimeters, 5.8 centimeters. I have to say the gallbladder is bad. Just has anomalous content, and the walls are kind of thickened. I have a moderate thickening of the slight thickening of the adrenal glands. This is probably due to hyperplasia. Nothing major. Peripancreatic fat is fine. There is no hydronephrosis, but there is quite a few microstones. And yeah, kidney, the bladder, urinary bladder is fine. There is an enlarged prostate. Diverticulosis right there. Rectum seems fine. There is small bilateral inguinal hernias, which are very, very common in the elderly, especially men. And this is the surgical scar, a Zivo C, in Portuguese it's chifo púbico. It goes from the pubis to the kyphoid process of the sternum. So it's called a chifo púbico in Portuguese. Uma laparotomia chifopúbica ou chifopubiana. And this is it. Let's just summarize it. And cysts and gallbladder stuff. Send this patient to sonography for scanning this gallbladder. Not my problem. Gallbladders are a sonography problem, not a CT scan problem. I'm sorry. It's their stuff. I don't do that crap anymore. I'm free of sonography. Free from hyperplasia of the adrenal glands. So we are done. Let's see. This patient has a previous exam. Let me just do the comparison with the previous exam. I'm pretty sure these findings right here are acute, and they could be the cause of the bloody stools. This patient is having some kind of bleeding in his feces. At least that's what the clinical history says. I wonder if it's just made up or if the patient actually has such complaint. No, just September. Let's see if I can download it. It was supposed to have this isn't it. Yeah, this is it. Now it's going to download. I had clicked the wrong exam. Oh wow, let's go. It's preparing, should start soon. And this is tough. It just won't download it. Tough streams, mates. Tough streams. System just won't send me the freaking images. Come on, send me the images. Send me the freaking images. And it goes like that forever. Oh, so it's downloading, it's coming, thank God. Better late than never. Let's see, it's here. Was that a post-op thing back then? So this is May of 2024. Oh, this was pre-surgery. So this is the tumor right here. See, this was a ascending colon tumor. This is the cecum. This is the ascending colon. This was the stenosing infiltrative tumor this patient had right here. So they took it off, and the patient was operated on, had gone through surgery, went through surgery back in May. So I was right about this. Isn't this not being a recent post-op? This is a late stage post-op. So this is probably inflammatory of some kind. So controle evolutivo. Can't really say much. I'm just going to say it's a post-op exam. And I'm done. I'm going to erase this. and I'm going to get another exam from the queue. Now a brain CT scan. Let's see. Downloading brain CT. This patient went through a cardiac pulmonary arrest and was saved. So they ordered a CT scan of the brain. He is 49 years of age, male. This is usually some major stuff. Usually, cardiac arrests lead to extensive brain ischemia. So beware, this is going to be awful. So scan, yep, it is. Remember, 49 years old. This is the brain. So this just is awful. Yeah. This is not a live brain. This is diffuse ischemia. This is awful. This is just, yeah. There is complete indistinction. I can't really tell what is cortex and what's white matter. I can partially tell on the cerebellum, not much. See, the fourth ventricle is all compressed and distorted. The sulci are all effaced, so are the cisterns. The supracellular system is still open, but it's reduced in size. And the ventricular system is really almost shut. So this is diffuse ischemia due to the arrest, the cardiopulmonary arrest. This is most probably a case of a brain dead patient, unfortunately. Let's just see how we are going to report this in as objective, as direct, as unobtrusive manner as possible, without being too harsh, of course. Start off from a normal template. I'm just going to translate to Portuguese what I just said in English and send it away. So let me see if there is cerebral herniation. No, there isn't. So it's sent, and I'm going to get yet another brain CT scan. Oh, is it for real? A 30 image CT scan? Really? No, come on, man. 68-year-old patient says he has some kind of weakness in his lower limbs. So I have here a ischemic lesion, chronic malacia, some acute ischemic foci or foci, or yeah, right there. This is basal ganglia lesions, yeah, bilateral and insularis regions, atherosclerosis, moderate microangiopathy, and moderate dilatation of the ventricular system. And let me just check the bones. Bones have been checked, and of course the orbits in this very shaky, horrible, terrible scan of the brain of this patient. So this is done. Let's just grab a template right there. Moderate. So it's done. Just summarize it. Moderate hydrocephalus and moderate white matter disease, microvascular white matter disease, and of course atherosclerosis. So it's done. There is another exam right there. Just going to check it out. It says I can't really understand this. I have no idea. Let me just see here. So just a crappy exam I reported earlier this morning. Oh, it's done. Not gonna waste more time on that. So there is a abdominal CT scan. Let's see. This is a 54-year-old male patient, and this is for kidney stones. Kidney stones. It's almost here. It's downloading. So, yep. Liver is fine. Gallbladder, pancreas, slight densification of the mesenterium. Kidneys are fine. No stones visible. Appendix is right here. Bladder is fine. The prostate is enlarged. Colon is fine. Fine. Stomach fine. Duodenum, bowel, as much as I can tell. Adrenal glands. Besides the enlarged prostate, I can't really say much. And he has major degenerative disease on the hips and the spine. And of course, bilateral small inguinal herniations. So I'm going to describe that, and I'm going to be clear. There is no signs of urinary stones. Now I'm going to put here just mention the bladder, because it's only partially filled, and I can't really say much. Oh yes, I need some sleep. And small inguinal bilateral adipose herniations. This is it. And yep. So since it's an exam for urinary stones, and there is no signs of urinary stones whatsoever, I'll state clear in the conclusion of this report that there is no sign of urinary stones nor hydronephrosis, just to make it easier to read for the referring physician. Enlarged prostate and a very bad case of arthrosis of the hips, especially on the left, right there. This is extremely painful and symptomatic. These are the right there, the inguinal hernias right there. So it's done, it's finalized, it's finished. Let's see if I have Anything else? No. Let's see, how long have I been streaming? It's 1 hour and a half already, guys. So I guess I'll take off. It's been a great first live stream on this channel, actual live stream. I guess I'll stream later today just to get used to it, because I'm kind of slow on the reporting. But if you guys enjoyed this stream, just hit that like button and consider subscribing to the channel. Activate that notification bell so you guys won't miss my next stream. And I'm pretty sure there is a video for today. No, not for today, for this week. And I'll be streaming quite often just to make my afternoons less boring. Thank you so much, Holden. I'll see you in the next stream. So long, guys.